Hi, Simone Biscaglia and Mike Gibson coming to you live from ESC 2023. And we're talking about the FIRE study, looking at a physiology-guided approach to complete revascularization in elderly people. Simone, talk to us a little bit about what you found.
Yeah, so basically we randomized 1,445 patients with at least 75 years of age and with a diagnosis of acute myocardial infarction that could have been both ST segment elevated or non-ST segment elevated, and with at least one clear culprit lesion and at least one non-culprit lesion in a vessel in which it would be possible to perform PCI if needed. So basically, we randomized those patients to two different approaches. The control arm was culprit-only treatment. So the treatment just of the culprit lesion at the time of the primary PCI for ST segment elevation MI or for angiography, after coronary angiography, non-ST segment elevation MI. And then the other arm of the study was complete revascularization guided by physiology. So any physiological assessment could be performed to assess non-culprit lesion, and the treatment in this arm had to follow the result of the physiology assessment.
And what time period was that that non-culprit PCI performed at the same sitting or within a week or a month? What was the time period for that?
Yeah, the protocol was very open about it. The only rule was to achieve the complete revascularization within the index hospitalization. So it was not possible to stage PCI at 1 month or 2 months or 3 months. So that was how it was structured because of the routine of the centers that were participating in the trial.
And what kind of physiologic measures did you use over in that non-culprit artery?
Yeah, again, it was a very practical approach in terms of organization of the trial. So any physiological assessment was possible according to the availability and the expertise of the centers participating. So actually we had 50% of patients in the physiology arm receiving FFR. And but it's interesting because there are also 35% of them who actually receive angiography-derived FFR. That is actually a kind of novel approach to physiology. But in those centers that were already using angiography-derived FFR, it was possible also to use it for physiological assessment.
And what did you find?
So basically, our primary endpoint was a patient-oriented composite endpoint because it was a strategy trial. So basically, we would love to see whether all-cause death, MI, stroke, and revascularization was different among the two arms. And so the primary endpoint was positive. So we had a significant reduction, 27% reduction of the primary endpoint that was significant at less than 0.05, it was actually 0.01. And basically, what was the most important message of the study is that among the different component of the endpoint, those were driving the reduction of the endpoint were actually the hardest one. So basically CV death and MI. So the secondary main endpoint was the composite of CV death and MI, and it was also significantly reduced in the physiology arm. So this is actually the most important message. As for the safety, because we had obviously a safety endpoint, it was the composite of acute kidney injury after PCI, significant bleeding according to the BARC classification, so BARC 325, and obviously stroke, we did not have a significant difference among the two groups. The hazard ratio was 1.11, so basically small increase in the complete arm without reaching any significance.
And was there any difference between the FFR derived invasively versus the angio derived FFR? I mean, the angio derived is less invasive. Any differences there in the benefits?
No, that's a very interesting question. Actually, we performed obviously subgroup analysis, and we did not find any interaction, any significant interaction among the different subgroups. And obviously one of the subgroups was the type of physiology used for the assessment. So obviously we were not powered to, find any differences among the different type of physiologists, but what we can say is that overall there was no difference according to the physiology measurement that was used in the trial. And I would say that another interesting point is that the percentage of positive physiology was actually 50%. So actually we were able to include a real complex population in terms of coronary anatomy.
And one issue that always comes up is how often did people cross over from culprit only to non-culprit? Were they pretty good about only doing the culprit, or was there much crossover?
No, actually, we obviously the protocol was very strict about it. So, and also regarding the ischemia-driven revascularization, we had very strict criteria for the adjudication of the event, and obviously the crossover was a major protocol deviation. So we were kind of fortunate, and obviously the investigator did an awesome job in a complex population, and the rate of crossover was actually very, very low, so less than 5%. So actually it was a very good results, also in terms of being able to give the patient the treatment that was actually randomized.
So the way I see this, interesting, some new progress during the index hospitalization. Other trials you could wait, but this is during the index hospitalization, an improvement in hard endpoints like cardiovascular death and MI, not just revasc, that it was good whether you used invasive FFR or the newer angio-derived FFR. So I think some important new lessons here. Thanks for joining us today. Important new work, and look forward to seeing it published.
Thank you very much, Mike.
And thanks to all of you for joining us here.
Thank you.